just do that.
Nope.
Hi there.
Yes. Doesn't want to click. Okay. All right, so welcome. Thank you guys for all coming. So the presentation today we've been doing with all of our in-house, out in the field staff, and just wanted to make sure that we were actually bringing you guys all in too, because we thought it would be really valuable for everyone to hear what the staff was hearing out in the field and the things that they're responsible for. So this is called the Triple Aim Plan for Success. Does anybody in here know what might be parts of the Triple Aim?
Make a lot of money.
Well, managing the money is a part of it.
Customer service.
That patient experience is another part. Behind me, yeah. You are the final session to go through this. So, right, so we're going to talk about our outcomes as well, and so we need to kind of balance that. So we are going to be looking at those different pieces. We're going to look at the satisfaction survey, which is called the HHCAP survey. We're going to look at that. We're going to look at Home Health Compare and star ratings and value-based purchasing, all these different things we need to be looking at. We're going to explain the process for determining home health payment and identify the triple aim for critical elements of success. Now, I know there's a couple of people from hospice in here. We have a hospice presentation. This is more going to be focused on the home care side. However, every piece that I'm talking about right now is either in place right now for hospice, and I'll try to mention that, or will be in place for hospice. And we now have an entire hospice tool like the OASIS tool, but we have an HIF, so this is all coming down to, and everything that we're talking about for home care will be coming down the pike, the same thing for hospice. All right, so let's move on. So the healthcare industry focus has been on these three areas. This is the healthcare industry triple aim: experience of care, the health of the population, and the per capita cost. So this is from the Institute for Healthcare Improvement, the IHI, and it's the triple aim. And so when you see regulations coming down from CMS, let's say, for Medicare, it's going to be about these different areas. That's the area that we're focused on as a healthcare industry. So we said, well, let's do the same thing here for us. Let's set up a triple aim plan for success here so that we can be successful in this healthcare industry. So our plan for success is excellent customer experience. And how do we look at that? We do our surveys that we send out to the patient. We'll talk more about those in a second, but there's hospice surveys, there's home care surveys, there's bereavement surveys. Excellent outcomes, there's different ways that we need to look at our outcomes, and we're going to talk about that. And then excellent episode management. And we need to be balancing right on that middle point. We cannot decide that it's all about the money, because then we won't have customers coming to us, right? We won't have provide an excellent customer experience. We won't have excellent outcomes. We're going to see how that's actually going to be a part of the money as well, bringing in quality outcomes, or be able to have partnerships with other people, other physician groups or insurance providers to keep people out of the hospital and have excellent outcomes. We need to balance and be great at all of these things. So that's where our plan for success is excellence in all these areas. So how do we know if we're doing a good job? How do we know? We have to collect and analyze data. You have to measure something to determine whether or not you're doing a good job at that. Does anybody know what the term benchmarking means? Are you doing versus your competitors? Yeah, so a benchmarking, you want to compare yourself to other agencies, to other hospices, to other home cares, to see who's doing great, who's doing the really great stuff, who has the really great outcomes, who has a really great satisfaction. Right, and then we're comparing ourselves to that benchmark. We're saying, well, okay, how far away are we from that benchmark? Where do we need to be? And then we use a tool, a service for us called Strategic Healthcare Programs. That's called SHIP. So you may have heard of SHIP, or SHIP dashboards, SHIP reports, things like that. So we use SHIP. So I'm just going to show you a little bit. I'm logged into SHIP, and I want to just show you a very small amount anyway of the capabilities of SHIP. So CHIP has dashboards like this. This allows us to look at our 30-day hospitalization, and then this is for different types of diagnoses. This is just a quick overview. This is looking at some of our other outcomes, such as our unplanned hospitalization. So you can see that there are several different outcomes here: acute care hospitalization, in emergency care, 60-day or 30-day rehospitalization rates. So you can see how that's scrolling, and you can look at, and you can actually take some of these off and look specifically, let's say, at all acute care hospitalizations, and you can look at the trends over time. So that's important to not just have one number, but to look at trends over time and what's happening with those. So we're able to kind of zoom in on those. We're also able to look at managing daily activities such as ambulation, bed transferring, bathing, improvement in surgical wounds and pressure ulcers, and putting pressure ulcer care into the plan of care, and did we do that care? Looking at how quickly we get in to see the patient, looking whether we did drug education, do we assess for falls, do we assess for depression, did our patient have flu or pneumonia vaccine, did we do diabetic foot care for all of our diabetes patients? All right, home health compare managing pain. Did we manage pain? Did we treat heart failure symptoms? Did we treat dyspnea? Did we see an improvement in dyspnea? So we're going to come back to some of those. These are outcomes. We can also be looking at our patient satisfaction surveys. All right, so this is our satisfaction surveys here. We're going to come back and look at that as we talk about the satisfaction surveys. Okay. So the first side of that triple aim is excellent customer experience. We have an HH CAHPS. It stands, Medicare likes to use letters and put them all together. So sorry for that. And the reason I'm sitting over here is because anybody who just came in late, we're actually recording this session so that anybody else who missed it can watch it. All right, only me being recorded. So the HH CAHPS is on our home health side. Home care side. We have a hospice CAHPS survey that gets sent out as well to our hospice patients or hospice caregivers after the patient passes, and we have a bereavement survey that is sent out. So this is the data that we collect on patient experience. So some people who came in, or maybe some people who came in late, I'll hand out. There is an example of one of our surveys. On the side. So if you have one of these, maybe you can just share it. I just want you to see it. Share it with your neighbor if you don't have one. And you guys need to have some here. I can pass some more out. This is a survey for the home care side. If you open it up, first of all, notice how long it is. Read that one. So these surveys get sent out to our patients by a vendor. They have to be sent out by a vendor. Our vendor is SHIP. So they send out surveys, and they don't send it out to everybody. It's a random selection, and the patient may get the survey while they're on service with us or after they're on service with us. In hospice, they get the survey after the patient passes. It's the caregiver who will be filling out a survey, not the same survey, a different survey. All right, in this case, you'll see that some of these questions on here that are gray are sort of shaded, right? This is how, I'm going to show you how we're reported off, and it's publicly reported how our patients answer these questions on Home Health Compare. So also, some people may not have been able to pick up. And by the way, if you came in late, please make sure you sign in. This is another handout. We have colored part on the back. This has a CAHPS survey composite questions. Anybody need any of these? All right. So the CAHPS survey composite questions. So because there are so many questions on that survey, they can't tell us the answers to publicly report all of the answers on how we're doing, so they combine some of the questions together. So if you look on the survey and you look on the composite questions, you'll see that the care of the patient, how well we take care of our patients, is a composite question that combines question 9, question 16, question 19, and question 24 from the survey that gets sent out to the patients. And then the other communications and specific care are also composite questions that involve different questions on that survey. Okay, is that clear about how that's sort of organized? How we score on these is publicly reported on Home Health Compare. Has anybody ever heard of Home Health Compare? You can go on to Home Health Compare. You can Google that. You can get on that site and you can put in the zip code for this area and you can find the Norwell VNA and you can see what our satisfaction surveys look like and what all of our outcomes look like. The information on Home Health Compare is old. It takes a while for CMS to get that published. So we use that SHIP database in order to look at more real-time data because we don't want anything bad going up publicly reported, right? We want that to look really good, so we want to catch problems with satisfaction, problems with outcomes in real time as quickly as possible so that we can figure out what to do about that and so that it does not become a part of our publicly reported outcomes as we can have an effect pretty quickly. So there are also other measures that are reported on Home Health Compare for the survey, and it's question, if you look, 2 questions are universal measures, they're called, and these are questions that are directly reported out to publicly reported. So it's question 20. Basically, it's on a scale of 0 to 10, how would you rate the home care? And what's publicly reported is the percent that rate us a 9 or a 10. So if somebody rates us an 8, doesn't go into that percentage, all right? Also, question number 25, would you recommend this agency to family and friends? That is also a percentage. It is definitely yes. That's the percentage. So if they don't check definitely yes, they check probably yes. That's not going to go in that percentage, right? So let's look at some of our outcomes on SHIP. Okay, so see down here, there's your care of the patient, the communication, the specific care, rating 9 or a 10, and recommended. All right, it's really hard, like spaghetti over here, so you can actually take some of those off and see if you, whoops, put one back on. It's hard to drive when you're on a big screen. Okay, all right, so here's the, would you definitely recommend percentage? And this is the trends over time, so I can see what the numbers are over time. So when you look at that, what do you think? Everybody's like, what happened in March? We were doing great. We're doing better now. What happened in March? We can actually click right in on that, and we can look and drill down and find out where those numbers came from, and we can see now on SHIP, you don't want to see red. Okay? We don't want to see dark red, all right? But we don't even want to see light green, to tell you the truth. We want dark green, all right? But these are the areas. Okay, we can see that 23 surveys were returned, and we can actually drill right down into those surveys, and we can see what happens here. So as far as really specifically looking at which patients, which clinicians, where's the red, where's the green, you know, how can we drill down? We can actually see comments if they allow us. Disclosure not authorized is for some people. So we can actually look into that to see whether or not what was the issue with that. Were we able to, you know, do something different in those cases? Can we learn from those cases? Okay. Okay. So that's just an example of what we can do for every outcome that's on there, not just this universal measure for patient satisfaction. Every outcome, every patient satisfaction measure, we can do that. So what we've been trying to do over the course of the past several sessions that was try to figure out, well, okay, what do we need to do to make sure we have excellent patient satisfaction? So we have excellent patient satisfaction. March was, besides March, okay, we are 5 stars that we have on Home Health Compare for our satisfaction. We want, that's home care satisfaction. We want to stay there, and we are very proud of that. And that's our clinicians providing excellent patient experience, right? So, but we came up with some other ideas to make sure that we can continue to provide that. And some of those were, and the ones that have a star next to them were mentioned multiple times in different sessions, consistent clinicians. If you have consistent people going in, seeing that patient, then that patient will have better care, will also develop a relationship with that person, right? And they really feel that that was something that would help with patient experience. Quality calls, that's something we're actually looking into. We have a committee that's looking at patient experience and customer experience, and one of those is putting into play having quality calls, like you guys do in hospice, actually. So that's calling up and asking and using some of the survey questions to see how's it going, because we want to catch somebody who's not having a good experience before they fill out that survey. We want to make sure they have a good experience. So having our volunteers work and provide quality calls, and we are going to be training some of Terry's volunteers to do that. That's great, and then they can be doing those quality calls, and we can find out what experience can be improved for that particular patient. Clinician calls, that's in between visits to see how patients are doing, if they're following through with things, do they need another visit, assessing them with a phone call. Assessing patient goals and focusing in on goals of the patient, because of course the patient's not going to have a very good experience if the patient doesn't get their goals met, right? And so using med lists in the book, by using med lists in the book that we have, our mission booklet, it says things like the purpose of your medication. And actually one of the questions is discussing the purpose of your medication. Did anybody do that with you on the survey? So by using the same med list, we would be able to use the same language, which actually comes up here, use the language of the survey. So so they'll say, did somebody set your home up so that you can move around safely? You want to make sure that you're using the same language. Discussing other services with the patient so that they know that we are a team working together. Informing the caregiver about the survey, because we don't really know who's actually filling out that survey or who's helping the patient fill out that survey. So the person who is the caregiver actually needs to know that, yes, we did go through the medications, and yes, we did discuss about what to put in place for preventing falls. Another one that had a star next to it was schedule. Calling the patients early, call with changes, involving the caregiver, use the calendar that we have in the book. So that's really important as well. Scheduling is one of the things that would provide a poor experience. Poor scheduling would provide a poor experience for patients out getting seen out. That would be a star one. Increasing the clinician staffing, decreasing their caseload, telling the patient about the survey and the importance that they have a good experience and that they call with any kind of issues. So if we don't catch them on a quality call, that they're calling us. Better communication between disciplines about scheduling, make sure the patient's calling us first, and talking about expectations for home care. Many patients have these expectations that we will be in there every single day, or we're going to be there for 90 days, we're going to be there for 180 days, we're going to be whatever. What is their expectation? And we have education within our admission booklet to make sure that we educate about that and help with them with their expectations. Explaining any type of processes like insurance processes that need to be put in place before we get supplies or other disciplines in there. Making sure we have a larger size for the calendar and that we have a DC plan. We're talking right away about discharge so that there's no surprise about a patient being discharged. Is there any other ideas that you have? Yes.
Just on the expectations of home care, even the expectations of symptom management of pain. A lot of people will say, oh, I don't have any pain after my knee or hip surgery because they're going to give me this. And then if they have pain, which they are going to have pain, that can kind of affect maybe they didn't.
So the expectations of a normal progression of their disease
or surgery is pain, absolutely. Yep. I know they're looking at that at the hospital too. Because if someone's having pain and they think they're not supposed to be having pain, they're going to have a negative experience.
We'll call them normal symptoms. Sure. Any other? And I told everybody, just come up, write something down, or you got an idea, let us know, let the manager know, let me know, let the patient experience, the customer experience team know that, because we want to make sure we continue to have that 5-star rating and provide excellent experience. All right. Okay, so let's move on. We have excellent outcomes and excellent episode management. They're related by something. They're related by the OASIS. So I'm just going to have you just take a quick look at the OASIS. So I'm going to pull it up on the screen. and pass it around. You don't have an Oasis. You don't want one. Just, I'm going to pull it up on the screen, so if you don't have one in front of you, we're going to scroll through it. I want you to get a sense of what the clinicians are doing out there in the field. When we say we're scheduling them for an Oasis, what does that mean? What is it that they have to complete? This is the start of care Oasis. These are all the questions that need to be answered. This is sort of the paper form. Of course, we're doing ours electronically. This is diagnoses. This is all the coding. This is living arrangements. This is how well they understand, what their pain is like, do they have any wounds, what's their skin like, 50 million wound questions, what their respiratory and urinary elimination status, confusion, anxiety, depression, how are they functioning, It's really important. Drug regimen review. It's a pretty long document, huh? That's a lot. And that's not the comprehensive assessment. All right? They do a comprehensive assessment, and then they answer these questions. All right? This does not count. The documentation that they need to document has to be in place to support their answers on this. This is not the assessment. All right? So they have to document, assess the patient, document their findings, and then score the patient on this Oasis. Okay. So it's a ton to do. They're doing it at, so let me just review. You're doing it at start of care, and they're doing it at discharge. They do a shorter version at a transfer because if a patient goes into the hospital, they don't have the patient right in front of them. If the patient comes back out of the hospital, that's a resumption of care. So the patient they'll be doing it at that time because they're going to rescore that patient. So there are different types of outcomes, and let me just pop back into my presentation. So we're going to talk about outcomes, and so the Oasis goes into looking at our outcomes, but it also goes into how much we are being paid, and we're going to get to that in a second. There we go. All right, so the Oasis assessment is a standardized tool, just like something like a Braden scale where you're looking at pressure ulcer risk. All right, it's just that it's a really big tool, and it has to paint the picture of how the patient is. On the hospice side, they have the hospice information set, and the hospice information set is much smaller than this. So they're documenting, and then we're answering questions on some of the things that they documented. But those outcomes are also going to be publicly reported on whether or not there are things in place. All right. The Oasis itself leads to a HERG code, which we'll talk about in a minute, and then it leads to our outcomes of care. Okay, so and what is an outcome? So when an outcome is looking at 2 points in time. Let's just call it start of care and DC. So let's think about ambulation. Did the patient improve? Did they stabilize? Did they decline? That's what we're looking for. In Home Health Compare, and anytime we get any credit for anything, the patient has to have improved. Think about our patients. Okay? They have to have improved. We don't get credit for stabilization, even though that might be a really good thing for some patients. Okay? So that's an outcome measure. That's the 2 points in time. There are also what's called process measures. Process measures are things like, did you do it or didn't you? So a pain assessment, you either did it or you didn't do it, right? So, or if you like a Braden scale, like risk assessment for pressure ulcers for a patient, you either did it or you didn't do it. That's a yes, no, there's no improvement or anything like that. And so it's the percentage of the time for those patients that you actually did that you assessed somebody for pain. Right? So we're going to look at another document that I'm going to pull up for you. If you don't have. I'll look at it together. This is a report from SHIP called Real-Time Home Health Compare. So these are the Home Health Compare measures that if you went on Home Health Compare, you would see these measures reported off on Home Health Compare and how well we're doing. This is a report that gives us more real-time data. So as soon as we have the discharges done, the 2 points in time, that data can actually flow to a report and tell us how we're doing. So it's not going to work through the whole thing, but we're going to go through just this first line, improvement in ambulation. It is a star rated one. We'll talk about what that is in a second. That's an O right there, not a bullseye. Means it's an outcome measure, means it's 2 points in time. And the actual is right here. So during this time frame, which is a year's time frame, right here, it's the dates for the year 2015, 85.8% of our patients improved in ambulation. That sounds pretty good, huh? But wait a minute. Because it's not as simple as that. There's something called risk adjusting. So CMS has this whole statistical manual on how to risk adjust, and risk adjusting allows different agencies that are different, really different, to be compared to each other. So some agencies might be really big and some are really small. Some have really old patients, some have really young patients. That's not apples to apples. So what CMS does is takes all the data, does some magic with it, and decides to how can I make this data be comparable to each, so each agency is comparable to each other. So that's called risk adjusting. And so our actual amount on Home Health Compare currently is, in this period of time, is 70.3%. So we dropped down. Our risk adjustment was not favorable on this, right? Our risk adjustment for the next period that was going to be reported would be 69.4. So we're able to see what's currently on there. Usually we run this report to see what's going to be publicly reported next. What's the next report going to look like? So we can see what our actual is, what's currently on CMS Home Health Compare, and what do we expect to see. Then we can compare ourselves to the state. That's all states that are reporting to CMS, and this one is all states here for SHIP. So anybody in our state that uses SHIP, which you would expect, somebody's putting money into looking at their outcomes, that they're probably going to be better, than the rest of people of the state. And then the nation is here, the CMS reported average for that, and then here is the SHIP. And then over here we can see our ranking among other agencies, not just what our patients report up, but our ranking among those CMS agencies nationally and SHIP nationally. All right. So the risk adjustment comes from answering the other questions on the OASIS. So answering questions like, does the patient have pain? What are their diagnoses? What is their risk for hospitalization? Do they have urinary incontinence? There is 3 pages worth of other answers, other questions that are involved in risk adjusting for improvement in ambulation. So the point of that is, it's not just did we score the patient correctly on that question, but did we score the patient correctly on every single question in the OASIS, which is why we have the PI department as well. The PI department does a lot of reviewing of those answers to make sure that that's appropriate. We cannot change the answer if we do not have any supporting documentation, which is why the documentation of the assessment is incredibly important for us as an agency. It is in the hands of that admitting clinician to document well on that patient so that we can have an accurate answer before we do anything for that patient. So we don't want to score the patient after we've already fixed their whole house so they can ambulate better. We want to score them before that, and there's whole conventions, and I teach a whole class on that. If you'd like to come to an OASIS class, you can come. But how to answer those questions correctly is one part of it. Another part of it is, are we treating the patient correctly so we actually are getting an improvement, right? So that's where our clinical pathways come into play, and looking and making sure that we're doing the right care for our patients. So it's scoring the tool right, and it's looking at that, whether or not we're treating the patient well. So do you see any red on here? Pain assessment. So, okay, pain assessment conducted. Did we do a pain assessment? You would think we would do it all the time. 99%. It's 99%. This is not a risk-adjusted one because you either did it or you didn't do it. So 99% puts us in the red. Why? Should be 100 because other people are doing 100. There is a very narrow amount, so most agencies are doing, let's say, between 97 and 100%, right? So where is our ranking in there? Why are we not 100? Seems pretty obvious. Aren't we assessing pain? It's the question. The question says, did you use a standardized validated tool to assess pain? The standardized validated tool that we have that only assesses one part of pain, which is normal, which is the intensity of pain, is a 0 to 10 pain scale, or the PAIN-ADD, which is for dementia. So if we didn't use a tool such as patient has no pain and we check denies pain and we didn't put a 0 in there, then we can't support that we used a tool. So we have to say we didn't use a tool in that. We did that, and then that comes out as we didn't assess pain. So that's how it's an example of how the questions are not as simple as they sound. And it's not that the clinician is not assessing pain, because they are. It's that is the way we have to answer that question. All right, so that is thinking about that for other questions as well. All right, so this the PMs are the process measures. So that's a process measure. We scroll down here, we see our 30-day hospitalizations right here, and our 60-day and our emergency room use. These are called claims-based outcomes. So this is reported to CMS by claims that the hospital puts in. So they put in a claim that this particular patient used the emergency room, or this particular patient was admitted to the hospital, and that data is collected here and reported off here. So we can look at that on our SHIP by like the number of transfers that we have done on that, but it may not be exactly accurate to what it is, what CMS has, because they do it by claims-based data. And down here, this is our HHCAHPS that we looked at already. Okay. So some of the excellent quality outcomes, ideas that we came out was to accurately document and support the OASIS answers. We have to paint the picture correctly whenever we're doing an OASIS time point, so that we have the correct information in there so that we can show improvement. Right? So we don't want to be documenting somebody, like we don't write down things like we just write gait steady, and then we're marking somebody that they need assistance with ambulation. Well, we don't have anything that shows in the documentation that they do need assistance with ambulation. Sounds like they're doing great. Their gait is steady. That's all you wrote about. So can we keep that? We might even have to move it to a higher level on that scoring because the documentation doesn't support it. So again, all of the clinicians have heard this and keep hearing it to try to make sure that the documentation supports that. And then the PI department can look and see what it is and trying to help with that to make sure. Perhaps they checked the wrong box on the scoring. That happens. You saw how wrong it is, and they just had to do all the whole OASIS assessment. So being able to have that documentation in place and being able to change it is great. So accurate OASIS answers, improvement in health-wise. So that was brought up, like, is there anything that can say, hey, you know what, you're documented all about how the patient has pain over here, but then on the OASIS you check they didn't have any. So trying to talking to each other and queuing, we don't really have that in place. So, is there anything that can happen in our electronic medical record to make it easier? Same-day admission communication between clinicians. That helps for scoring. The OASIS has to be done by one person. It's usually the admitting nurse or the therapist who goes out, but if there's a therapist who went out the same day, they can talk about how that patient did with ambulation. And the clinician who is doing the OASIS has to have seen the patient do that, the ambulation, but they can talk about that scoring and how to document against it. Don't overbook clinicians. They won't have time to do everything they need to do, right? I'm done. I'm hot. Do you have any more hot? Oh my God, that was me because I was just, here talking. Okay. Now you're going to be cold. So I'm going to wake you right up. Okay? All right. So don't overbook. Increase staffing. All right. Consistent team meetings to try to make sure we're talking about the patient and that we're making sure we're treating the patient well. Using telemed as a way of managing the patient, making sure we're doing really good med reconciliation so that the patient is using their medications, that they're improving, that they're not going to the hospital because they didn't use their medications correctly, and looking at using specialists, using our pathways to make sure we're caring for the patient during the episode of care correctly. Is there any other ideas that you guys have? Check with the VOCM specialist. Okay, so other specialists.
It's not an idea, it's a non-clinician question.
Sure.
When do they fill out, they do the tablets, their tablets, right? When do they do that? While they're at the patient or after the visit, before the next visit, or?
That's great. So accuracy and documentation really needs to happen. It needs to make sure that you do the documentation as soon as possible, because as you leave more time, you become less accurate. So what's advised is to try to do as much in the house. You cannot do that OASIS in the house. Okay? But you should be able to document a lot in memories. It's the documentation that's supporting the answer. Right? So if you can get as much information in your documentation in the house, some of the questions like the depression screening, they should be doing in the house, but most of those scoring depends on what you've written in your documentation. So they should be doing that as soon after. So our recommendation is that they take the time after the visit to try to complete that documentation before going to the next visit. If that can't happen, I always recommend leaving a time in the middle of the day, a large amount of time, like a lunchtime kind of thing, to try to get your morning stuff done before going on to the afternoon. Because you cannot do 2 or 3 OASIS in a day and expect to do the documentation accurately at the end of the day. Okay, so that goes with, again, supporting that documentation accuracy and how can we get that to be accurate.
Just on that, for patient satisfaction, I know that a lot of patients really don't like when the clinician spends 100% of the time on the computer. So I think, to your point, half in the home and then half wherever else.
And I've been out in the field for like 18 years. I was out in the field doing the OASIS and everything. So I know that you can do things. You can do stuff. You can spend time with the patient. You can come back, and you can also talk to the patient and just say, listen, it's really important that I get this information on this assessment time in here so it's accurate, and then other people can see, you know, how you're doing or what your assessment says. I think if you bring, you know, some people will not like it at all, but some people will understand that you do have to get that in there for accurate assessment. Okay. Any other ideas? Feel free to come and write one up there, or let me know if you have any other ideas. Star ratings, you saw the star ratings. So what we do, I know you can't see this, and that's okay if you don't need to see this. But this is a report that we get that tells us for the different measures that had the stars next to it on that other report, they're all listed at the top. And then these gray areas tell us where we land. And then depending on what other people are doing as well, we get a star rating for different. So we get a 4-star, we might get a 3.5 star, we might get a 2.5 star. That's our hospitalization rate. So what you're looking at is it's sort of like a bell curve. So it's kind of not like TripAdvisor. You know, you go on TripAdvisor, you're like, I'm looking for a 4-star hotel. You know, that's just from people like, you know, putting in the 4 stars, they do the rating. It's not on this bell curve where the average is always 3 stars. Well, this is like that. So the national average for star ratings will always be 3 stars, even if everybody improves, because we're competing with each other. Okay? So these numbers are now showing us competing and what our score is ranked against other people's scores. And so they look at certain different measures, and then they give you one final score. And we have right now 4.5 stars for our outcomes and 5 stars for our patient satisfaction. Right? So of course we want to be a 5-star because we're never satisfied, right? So we want to be up there, and it's really important, and you'll understand why when we get to value-based purchasing at the end of this presentation. So now we're going to move into excellent episode management. So that OASIS that we were just talking about has not just the outcomes that it does. We're not looking at 2 points in time. We are also just looking at how is that patient being scored at the start of care. How those scores land go into a code. It's called a HERG code, and it's different domains to that, and you actually have a handout that I'll have you take a look at. And I'll bring it for a few more around. It is there's two of them here. One is called a worksheet, and one is about diagnosis screening. Take one that has the one that has the worksheet. All right, it basically looks at clinical domain, functional domain, and service domain. All right, so the clinical domain is a C, and you get a score for that domain depending on how the clinician scores the patient and what diagnoses are chosen. So getting as much information on intake as possible is really important to make sure we have the accurate diagnoses and that we do the coding correctly, because we're going to get diagnosis scoring. And that's one of these forms is about diagnosis scoring. Depending on what diagnoses you list, you get different points. They're called case mix points. And that depends on how many points you get, depends on whether or not you're in an early episode, which is the first or second episode of care that the patient is on, or a later one, a third or fourth episode. So let me just describe what an episode is. We score a patient at the beginning of an episode of care. It's a 60-day episode of care. It is a lump sum amount of money that we actually get to take care of that patient, to provide all services during that 60-day episode of care. 70% of our patients are Medicare patients, and that's how we get paid for them. Right? So we are scoring right at the beginning, and we get, again, we get points for different diagnoses. We get points for pain or dyspnea and how we answer those questions. Whether the patient has wounds, we get a C score. We get an F score for the functionals. That's how well they're ambulating, how well they are using their bathing or getting up and moving around out of bed. Transferring. All right, we get scores for that, and it becomes an F score. The S score is the amount of service needs, and that's therapy visits. So we estimate the number of therapy visits, and then they give us a score that's an S score. So we end up with a CFS score. Those are based on those episodes and these different items, and we come up with a score. So I'm going to give you some examples of what that will look like. So in this case, right here on this particular patient, luckily we don't have to fill out paper worksheets on every patient. We do have a system that will do that for us. So the clinician scores the patient, the PI goes through that, and they try to make sure that the scores are all correct, and then it will land over here on a screen and it will add it up. So in this case right up here for the clinical dimension, the patient scored over 9 points, so they have a C3. They're over 7 points, they have an F3. And they're over 3, they have a 3, which is 7 to 9 therapy visits, so they're in the S3 category. This is about supplies that are added on afterwards. So the patient has a C3, F3, S3. They have a case mix weight of 1.1906, and their payment that we're going to be receiving, it may not be right. This is a little, you're the only one in here who might know that this is not. Concept is correct. $4,126.22 to take care of that patient. It's a bundled payment to provide all services in for that patient so we can manage this money. This is the best way for us to get paid right now, is to be able to manage the money. But we have to manage that, and that's called episode management. Okay? So another example right here. This is just a lower one where we have a C2, F2, S1. Case mix weight is down a little lower, and we get a payment, a rate for that episode of care. Okay? So that's, many clinicians didn't realize that. Okay? And it is new. We have a lot of new people too that are on here too. So what they've been talked about is making sure that the managers are talking about that on a case-by-case basis. This is what you have, when you score somebody, this is what the case mix was. This is what your case mix, overall case mix is for several different patients, like for over the course of time. So over a year, you can look at somebody's case mix and see what they're scoring, how they're scoring. That being said, a lot of it is not just always tied to one person. It's very hard to run a report for just one person because many times there are multiple people involved in the case. So it might be a different admitting clinician versus a case manager for the case. Okay. All right. So this is our amount of money. We need to manage it. So what are some of the things we need to look at to manage that money? Visits. Visits per episode is one of the things we're looking at. For therapy visits, we get extra money for taking care of that patient. If we needed to provide more therapy visits, we get paid extra money for that. So the way that we are paid for this is we get about 60% up front to start off with, and at the end, they figure out what services, what do we do, how many therapy visits do we do, and we will get an amount of money that goes with the therapy visits and other things that go into that as well, right? Like supplies and things, okay? So we have 2 points in time that we get kind of a payment. It's a wrap, submit a claim. All right? So we can manage the visits per episode. So we want to be looking at how many nursing visits are we doing, right? Are they appropriate? And that's what our focus has always been. If we say we only want you to do 3 nursing visits on every patient, well, how is that going to impact outcomes and patient satisfaction too, right? So we want to do what's appropriate for the patient. We also have a very highly skilled rehab department that can be assessing the patient as well. So working as a team is really important. So these are some of the ideas: accurate diagnoses, because we want to make sure we get the right coding and we get the right information and we get the right amount of money for taking care of the patient, and so they have different diagnoses. Clinician education on specific money, so the clinicians, case managers actually know this is how much money that I have to spend on this patient over the episode of care. Look at how much I've projected for nursing visits. Look at how many home health aid visits that we've projected. So they actually are knowledgeable about that. That's writing their visit frequency orders and thinking about the visit frequency orders over that time frame and managing that, saying, okay, should I be tapering this? You know, what's the most appropriate? How many visits do I think I need to do as a nurse over that time frame? That may change, and it's okay. It could change in either direction. As therapy, one of the questions on the OASIS actually is, how many therapy visits are you going to do? Because that's all they know how to pay that S score, right? So PT, OT, and speech have to literally come up with a number. I'm going to do 10 therapy visits, or I'm going to do 2 speech therapy visits, and then they get all added up. So nursing can be thinking the same way. It may not work out like that. To the best of your ability, at that point in time, how many do you think you need to do? We maybe need to do less. But over the course, because the patient gets better, maybe we need to do more. The patient has some type of change. All right, but we want to try to the best of our ability to get our visit frequency orders correct. Case management meetings, meeting regularly was another idea with the manager to make sure that they're providing the appropriate care and not over visiting, and that we get specialists in there. We talked about specialists for outcomes. Well, specialists over here too. Get the wound care specialists in there. Maybe we're not using the right wound care products and we're visiting too frequently to change the wound. Right? So we have some specialists. We have a lot of other specialists too. We have nurse practitioners here. Are we providing the right care?
Or the nurse practitioners with the physician offices.
Contacting the physician, working well with that, and remembering, I've been talking about that, remembering that the MD office, the MD is a part of the team. So communicating as a team and communicating with the MD is really important to provide, managing money as well. I mean, they're all related, right? Mm-hmm. So communicating about visit schedule with other disciplines to make sure that you're not having like 5 people go out at the same time, and do we really need to do that? Was that appropriate? MD visits, sure, let's see what I want to say, decrease canceled visits. I'm not sure what that.
Making sure that if the patient has a physician, that the nurse isn't scheduled to go out and go out.
Or that they don't, actually what may have come out of this is that they don't cancel the MD visit too. Yeah. Decrease the number of canceled MD visits. And then just one of the other ideas that someone came up with, is there a benchmark for the number of visits that we should be doing for each HERG code? And I don't know that that actually exists from a research standpoint, but that's a great idea to be looking at our practice pattern for the number of visits that we do for each of those HERG codes and the types of visits that we do. Any ideas you have?
Does the telemed still increase visits?
The telemed doesn't necessarily increase visits. I think we're hoping it's going the other way.
But I think we looked at it a couple of years ago, and we found that it decreased rehospitalizations, but it increased visits because we went out there.
Yeah. So
that's kind of
just put a little question mark. Are we using telemed appropriately? Are we using it just as a way of monitoring the patient, or are we using it as a way of teaching the patient? There's really 2 different types of patients that could be on telemed, and monitoring might actually keep somebody out of the hospital, and we might need to monitor that whole episode of care because that patient is not able to really learn. Then there's the other type of patient that we need to make sure that they are learning how to manage their chronic disease. And maybe this is just an adjunct for learning that we're going to pull that out sooner, so we can make sure we're using telemed. All right, so, and again, any other ideas? And think about, you're all in different roles here. You have one little piece that you're doing. How might you be able to help with these different areas of the success, triple aim success? Before you all leave, I want to tell you about a wonderful opportunity we all have to participate in a pilot program called value-based purchasing. Yeah. So CMS, as Medicare, has chosen Massachusetts as one of the 9 states to pilot a program called value-based purchasing. And this is something we knew was coming. This is pay for performance, you might have heard. So basically, you will be getting a penalty for doing that job or not
doing a great job taking care of patients, and you could get a bonus for doing a good job, right? And you're compared against other agencies. And in this case, we are competing against agencies within the state of Massachusetts as compared to the whole nation. So some of the home health compare data you see is kind of a comparison to the nation. You can see a comparison to the state. So in these cases here, we are just competing against the other agencies in our state. And it's not just like one measure. We never knew what they were going to pay us for performance on. Well, of course, they've complicated things and made things, multiple measures. Some of them are the outcome measures we talked about. Some of them are the patient satisfaction measures. And then there was, of course, 3 new measures, because why not? Give us a couple other things to do. So that is collecting data on herpes zoster, collecting data on advanced care planning, and whether or not employees get the flu vaccination. And those 3, we actually just get points just for collecting information for the government for that. But eventually, there's going to be benchmarks. There's no benchmarks on that yet, like that will say whether or not it's a high level or not. So we're not necessarily competing. We're just putting that information into a system. And we start putting that in October, those new measures. But it's this year that they're looking at our outcomes for everything else. All right, so I'm actually going to keep this as simple as possible. It's much more complicated than what I'm going to say to you, but this is basically how we're going to be paid for performance, all right? So if you're looking at this slide, this whole area underneath this area here, that is all the agencies in Massachusetts, home care agencies, okay? So this, for each measure, they figure out achievement points. This is for whether or not the patients got their pneumonia vaccination. So if you took all of the agencies and split them in half, right, so 50% are here, 50% are there, what number would you come up with for percentage of patients who got their pneumonia vaccination? In this example, it's 47.4%, so that's considered what's called the threshold. If you take the top 10% and you get an average of what the top 10% of agencies, what their number of patients that get the pneumonia vaccination is, in this example, it's 87.5%, so that is your benchmark. That's the agency's doing a great job. So we're going to get points on this. Where do we fall? All right. If we fall over here, we get 0 points. No points. We're below the threshold. If we are above the benchmark, we get 10 points. If we are somewhere between the threshold and the benchmark, we get somewhere between 0 and 10 points, depending on where we fall. That's for each measure that they are wanting us to report off on, all right? So for each measure, we need to make sure that we are doing a good job so that we get high numbers of points, because then all of those are going to be added all together into what's called a total performance score. When that total performance score comes out and we're compared to all the agencies in the state, we are going to again fall on this bell curve. Where are we? Are we at the high end where we're going to get a bonus in the first year? This is with our reporting year, but in 2018, that's when we will either make or lose money. Somewhere between 3% loss of money up to a 3% gain in money. We will fall somewhere on that continuum. We are going to fall high on that continuum. We are going to make money in that year. But look at the numbers as they go up. How much money? Some agencies are going to lose money. Agencies are going to lose money at each of these time points. What's going to happen to those agencies? They're going to go out of business. They are the low-quality agencies going out of business. It's a good thing for patients. Low-quality agencies going out of business. What does that do to our competition? Makes it a lot tougher because we're competing with each other. We can't just keep our scores where they are and think we're going to be great. We are competing with all the other agencies. So we get rid of the crappy ones, and now we're competing with high-quality agencies for money. So our outcomes need to be extra good. Excellent outcomes. Excellent patient satisfaction. And then excellent management of their episode. Hospice is going to go through the same thing. They got a value-based purchasing they're talking about, in the future. They have expanding that hospice information set for collecting data on outcomes. It's going to be publicly reported. It's not yet. It's going to be following the same path.
So it's tough. We are in a great position where we are right now. We just have to keep up the good work, right? We need to make sure that our documentation accuracy is really good. It really reflects on that value-based purchasing, being paid, that financial integrity, making sure that we score the patient correctly, making sure that our outcomes are great. Our outcomes need to be great because it shows our patient quality, whether we like it or not. That's what shows our patient quality. That's publicly reported to patients, to consumers, to different agencies, other agencies, to insurers, to hospital systems, to physician groups. They're all looking at quality outcomes. And that we have talked about for a while with our staff that could lead to some potential partnerships because we have such good quality outcomes. And it has. Right now, we are in a pilot program with Unicare, which is an insurer that we are a part of the Visiting Nurse Association of New England, and the outcomes of the Visiting Nurse Association of New England agencies are really high, and because of that, they have chosen us to work with their patients staff will learn more about this in the August education, but basically it's our CHF and COPD patients that come from Unicare are in this pilot, and we need to follow our pathways to take care of that and make sure we have good outcomes with those patients. We are paid differently. We're unsure how we're actually paid right now, but we are paid differently than Medicare. Well, anyway, whether it will benefit us or not, we'll find out. I mean, hopefully it will be, but these patients don't necessarily have to be homebound. So this is not meeting eligibility, which is a home kit bound is one of the eligibility requirements for Medicare. So we're expanding our services to provide to a different group of people. And that's good. We want to make sure that we are, making sure we are able to provide services. So we may be providing services to different types of groups of people to make sure that we stay really, viable in the future. Right? And that might expand to different diagnoses or other insurers. And we're actually working with Harbor Medical as well to work with them to take care of their palliative care and their heart failure patients. So it's because we have such great quality outcomes. And so we're starting to see that those relationships are forming now to build those networks to be able to take care of patients because we do such a good job. All right, so we've listed out some critical elements to think about and what we might be able to change. We are all involved. We are all keys to success. So how can you, in your job, think about working toward excellent patient satisfaction, excellent quality outcomes, and excellent episode management? Everybody in here is doing a different job. How can you support the clinicians out in the field and things that you're doing so that we are successful in the future? Does anybody have any questions? Okay, you have a post-course eval. If you don't, there's someone sitting up there too. Love to get your feedback on this. Any of the handouts that you had, you can give them back to me unless you absolutely want to have them. I'll reuse them. And any questions you have, I'm here, so please let me know if you have any questions. Thanks, Suzanne.
So it's which patients talking about vaccination? It's which patients get the
No, actually, pneumonia is a regular one that we normally report upon OASIS, so the new measures are actually Herpes zoster.
Yeah,
And
Hi, Christine.
I have mail for you.
Yes or no? That's what you do, but you really want to support it.
Yeah. So we're trying to get more doctors' offices. I'm also trying to as well. It should say what is organized. That's my idea. You know what I mean? They're not looking here, they're looking at a percentage. Just overall. And have you consulted your other agencies? Okay. Some people won't want to. And actually, if one of them, like I said, whatever. Yep. Then I'll look at that point. So, for you, Yeah, but yeah,
I didn't even know we have pre-claim review coming up. I didn't even mention that. So possibly starting in January, we are lumped together with agencies from horrible states like Florida and some of these big Massachusetts as well to send in surveys and so on, so they'll pay us.
Thanks, Susan. But Joe,
We're not sure what they want. They said exactly what they want.
For the end? For the end?
Usually they give like 60% up front and then
They'll give us the rest, but before we submit the claim, we have to submit data. They're not going to submit that.
So he's doing that.
Pre-claim review. Don't submit that. And drop our final.
That's all right.
Oh, my God.
I'm trying to work on that date to start that.
If I know
Starting in
you.
Illinois, in August, and so we have to, we'll learn from them, maybe they'll push us off, maybe Illinois first. Illinois, it's August 1st. So that's a time thing. So that's, we've got to get everything back in, otherwise we're holding our.
See, right now, the space debates are killing us. We're doing as best as we can, but we're really only. When
No,
we.
and I'm saying that you're talking about.
Yeah, yeah.
I'm just starting to get started on it right now. All we can do is-
But it's funny.
So,
That put it in it.
but I asked the staff to do today, and nursing staff.
All the sections to you, like, oh, it's great.
And then it's,
Yeah.
I go to every.
I know. Is it not saying?
Yeah, we need that.
Yeah.
It just charged coach instead of the NX.
It was, you know, I thought that was gonna do that.
They're not writing
Yeah.
down.
Anyway.
So yeah, I'm surprised they don't have to document that. I mean, isn't somebody else holding them to some documentation standards?
Yeah, I don't think so.
Oh my gosh, I just realized that I was talking with you. I gotta go.
Sorry, Sunday.